Welcome, future nurses. Today, we are diving into one of the most critical and life-saving areas of nursing practice, the care of clients with neurologic trauma. Injuries to the brain and spinal cord can completely change a person's life in a matter of seconds, and as nurses, our role is to act quickly, prioritize safety, and prevent complications. In this session, we will explore the pathophysiology, priority assessments, and evidence-based nursing interventions that guide the care of clients with head injuries, spinal cord trauma, and increased intracranial pressure. So, get ready to strengthen your clinical judgment and critical thinking as we uncover high-yield NCLEX strategies and essential nursing pearls to help you master this topic. Before continuing the NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep, interactive live classes, and easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for revision, a ready-to-use student planner, Nigerian NIRA questions broken down in detail during comprehensive lectures. This isn't just another review, it's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources. To keep you ahead, let us move forward with another critical trauma scenario that often appears on the NCLEX. Imagine this. A nurse stops to provide emergency assistance after witnessing a high-speed motor vehicle accident. One victim has been ejected from the vehicle and is lying on the ground. During the initial assessment, which findings should the nurse recognize as the most critical indicator of a serious head injury requiring immediate intervention? Here are the possible options to consider. The first option is that the victim reports having a severe headache. The second option is that the victim asks repetitively, "What happened?" The third option is that the victim appears hesitant to move. And the fourth option is that the victim has clear fluid draining from the ears. The correct answer is option 4. The victim has clear fluid draining from the ears. Now, let us carefully unpack why this is the priority. The presence of clear fluid draining from the ears, known as autouria, following head trauma is strongly indicative of a cerebrospinal fluid leak. This usually results from a basilar skull fracture, which is one of the most serious injuries because it signals a tear in the meninges. This tear creates a direct route for pathogens to enter the central nervous system, dramatically increasing the risk of bacterial meningitis. It also reflects significant skull-base disruption, which may be accompanied by intracranial bleeding, swelling, or even impending herniation. That is why this sign requires urgent recognition, strict head and neck immobilization, avoidance of suctioning or nasal packing, and rapid transfer to a trauma facility for neurosurgical evaluation. When we look at why the other options are incorrect, let us begin with option 1. A severe headache is certainly concerning after a head injury, as it may reflect concussion, intracranial bleeding, or rising intracranial pressure. However, a headache alone is a non-specific finding and does not immediately confirm a structural breach of the skull or meninges. Option 2, where the victim repeatedly asks, "What happened?" reflects confusion and short-term memory loss, which are hallmarks of concussion and post-traumatic amnesia. This does require careful evaluation, but it is not as life-threatening as a cerebrospinal fluid leak. Option 3, in which the victim is hesitant to move, could be due to pain, musculoskeletal injury, or fear. It does raise concern for spinal injury and therefore warrants immobilization, but it does not specifically point to a high-risk intracranial complication in the same way that cerebrospinal fluid drainage does. From a clinical standpoint, nurses must always prioritize the trauma survey by addressing airway, breathing, and circulation, while protecting the cervical spine. Clients ejected from vehicles are especially vulnerable to spinal cord injury. In suspected basilar skull fractures, remember that other red flags include raccoon eyes, Battle's sign, and blood behind the tympanic membrane. The biggest complication of a cerebrospinal fluid leak is meningitis, so strict infection prevention is essential. Management involves gently collecting drainage on sterile gauze to test for the halo sign while avoiding suctioning, packing, or insertion of nasogastric tubes which could worsen intracranial exposure. Here is your NCLEX success key. In trauma questions, always select the finding that signals direct neurological compromise or life-threatening infection risk. In this case, clear fluid from the ears is a red flag hallmark of a basilar skull fracture until proven otherwise. And finally, here is the Stancoast Pearl. Clear fluid draining from the ears or nose following trauma means cerebrospinal fluid leak, and basilar skull fracture until proven otherwise. This one clue takes precedence over headache, confusion, or reluctance to move because it indicates a central nervous system breach with the highest risk of meningitis and brain herniation. Let us move into a vital trauma-focused NCLEX practice scenario to sharpen your emergency prioritization skills. Imagine a nurse is the first responder at the scene of a motor vehicle accident. One victim is lying on the roadside, alert but dazed, and is complaining of neck pain. The nurse observes that the client is breathing spontaneously with an open airway, has a regular pulse, and is able to speak in full sentences. Meanwhile, several bystanders are crowding around. The question is, which nursing action should the nurse implement next? Here are the possible options to consider. The first option is to maintain the victim's present position without movement. The second option is to assist in obtaining the victim's insurance card from their wallet. The third option is to cover the victim with a light blanket. And the fourth option is to offer the victim a small amount of water to drink. The correct answer here is option 1, which is to maintain the victim's present position without movement. Now, let us carefully analyze why this is the most appropriate action and why the other options are incorrect. Beginning with option 1, this is correct because in trauma situations, the nurse must follow the ABCs of emergency care, which include airway, breathing, circulation, and cervical spine stabilization. Since the client is already alert, maintaining spontaneous respirations, and perfusion is intact, the priority shifts to preventing secondary injury. Complaints of neck pain strongly suggest a possible cervical spine injury. Moving the head, neck, or spine in this situation can cause catastrophic outcomes such as spinal cord transection, paralysis, or worsening neurological deficits. That is why the nurse's most critical action is to keep the client in their current position, stabilize the head manually if necessary, and prevent any movement until trained emergency personnel can apply cervical immobilization equipment. This aligns with advanced trauma life support guidelines and NCLEX prioritization strategies, where airway is secured first, and then spinal stabilization immediately follows. Looking at option 2, obtaining an insurance card may be practically useful later for hospital admission or legal documentation, but it does not play any role in saving the victim's life during the critical golden hour of trauma care. Choosing this action distracts from the urgent nursing responsibility of preventing physiologic compromise and could delay immediate stabilization and transfer to higher-level care. Therefore, this option is incorrect. Moving on to option 3, covering a victim with a blanket is appropriate in circumstances where the environment is cold, the client is in hypothermia, or shock prevention is required. However, in this case, there is no mention of environmental cold or signs of hypovolemia. While keeping the client warm is a good supportive measure, it is secondary to ensuring spinal stabilization. Performing this step before stabilizing the spine risks delaying prevention of neurologic injury, making it an incorrect choice. Finally, with option 4, offering water is contraindicated in all trauma cases until injuries and surgical needs have been evaluated. Giving oral fluids risks aspiration if the client loses consciousness, and it violates the nothing by mouth NPO precaution, which is essential in case emergency anesthesia is needed. Furthermore, neck pain already suggests possible airway compromise, and swallowing could worsen airway instability. For these reasons, this action is unsafe and incorrect. Here is the clinical takeaway, also known as the STANCOAST Pearl. After confirming that the airway and breathing are intact, always assume cervical spine injury in any trauma victim with head or neck involvement until proven otherwise. Never move a trauma patient unless absolutely necessary. Improper movement is one of the most common causes of secondary spinal cord injury in pre-hospital care. And here is a final NCLEX strategy tip. When several safe answers are provided, always prioritize the one that prevents the most serious or irreversible complication. In this case, spinal cord damage leading to paralysis. Let us now turn to another essential NCLEX-style emergency scenario, one that directly connects nursing judgment with both ethics and the law. Imagine a nurse is the first responder at the scene of a motor vehicle accident. The central question here is to reduce the risk of liability while acting as a good Samaritan, which is the most appropriate action for the nurse to take. Here are the available options. Option 1 is to avoid giving the accident victim any personal identification. Option 2 is to remain with the accident victim until paramedics arrive. Option 3 is to provide a report of who caused the accident to law enforcement officials. And option 4 is to let others at the scene provide direct care. The correct answer is option 2, remain with the accident victim until paramedics arrive. This is the correct action because Good Samaritan laws exist to protect healthcare providers who voluntarily stop and render care during emergencies. However, these protections carry an important condition. Once the nurse begins providing care, they must remain until someone of equal or higher training, such as paramedics or physicians, assumes responsibility. Leaving the victim before that point may be seen as abandonment, which could result in negligence claims. Staying with the victim not only ensures their safety, but also fulfills the ethical principles of fidelity, which is keeping a professional commitment, and non-maleficence, which is avoiding harm. On the other hand, option 1, avoiding giving personal identification, is incorrect. Withholding identification has no bearing on liability protection. Good Samaritan laws emphasize good faith, reasonable care, rather than anonymity. In fact, refusing to identify oneself could create confusion or hinder the continuity of care. Option 3, providing a report of who caused the accident, is also incorrect because it shifts the nurse's focus away from client safety toward legal responsibility, which is not the nurse's role at the scene. Accident causation is determined by law enforcement, not healthcare professionals. If the nurse provides opinions rather than objective clinical observations, they may actually increase their own legal risk. Finally, option 4, letting others at the scene provide direct care, is unsafe and inappropriate. Allowing untrained bystanders to take over care can expose the victim to further harm and expose the nurse to liability for abandonment. Once care is initiated, it must be continued until a qualified professional formally takes over. From a broader perspective, Good Samaritan laws vary slightly depending on state or country, but they consistently protect providers acting voluntarily, within their training, without gross negligence. Nurses in such settings must prioritize the ABCS, airway, breathing, and circulation, while avoiding actions outside their competency or resources. Ethically, the guiding principles here are beneficence, fidelity, and non-maleficence. Here is the Stan Coast Pearl to remember. Good Samaritan protection ends where abandonment begins. Once you start providing care, your responsibility is to stay until a qualified professional arrives. Liability is reduced not by leaving the scene, but by ensuring continuous, safe, good faith care until proper handoff is achieved. Let us transition into another critical NCLEX-style trauma question that highlights the importance of prioritization in emergency nursing care. A nurse in the emergency department is caring for a client who is the victim of a motor vehicle accident and is awaiting physician evaluation. The client is restless, reports severe neck pain, and is at risk for both spinal cord injury and increased intracranial pressure. The question asks, which position should the nurse place the client in while awaiting further diagnostic imaging? Here are the options to consider. The first option is dorsal recumbent with the legs elevated. The second option is supine with the head slightly elevated. The third option is flat with a rigid cervical collar or neck immobilizer in place. The fourth option is right lateral with the neck flexed. The correct answer is option 3, flat with a rigid cervical collar or neck immobilizer in place. This is the safest position because until a spinal cord injury is definitively ruled out by imaging, such as CT scan, MRI, or X-ray, the nurse must assume cervical spine instability. Keeping the client flat prevents any motion that could worsen vertebral displacement or cause spinal cord compression. The cervical collar or manual inline stabilization ensures that the neck remains immobile, which minimizes the risk of secondary spinal cord injury. Although elevating the head of the bed can reduce intracranial pressure, it cannot be done safely until spinal stability has been confirmed. In trauma nursing, protecting the spinal cord always comes before intracranial pressure management, because even slight misalignment can cause irreversible paralysis. Looking at why the other options are incorrect helps solidify this concept. Option 1, dorsal recumbent with the legs elevated, resembles the shock position and is contraindicated in suspected spinal trauma. It increases venous return, raises intracranial pressure, and worsens possible brain injury. Option 2, supine with the head slightly elevated, may help venous drainage and lower intracranial pressure, but elevating the head without cervical stabilization risks dangerous neck movement. Option 4, right lateral with the neck flexed, is extremely unsafe because flexion of the cervical spine promotes cord compression and neurologic decline. Airway protection in trauma should never involve neck flexion. Instead, the jaw thrust maneuver is used to avoid movement of the cervical spine. From a clinical reasoning standpoint, trauma care follows the primary survey with a strong focus on airway, breathing, circulation, and spinal protection. According to Advanced Trauma Life Support Guidelines, all trauma patients are considered to have a spinal injury until proven otherwise. That is why immobilization on a flat surface with a cervical collar is the standard of care. Only after imaging confirms stability can measures like elevating the head of the bed be safely introduced to manage intracranial pressure. Here is the Stan Coast Pearl to lock this concept in your memory. Immobilize first, elevate later. Whenever spinal cord injury is suspected, protecting the spine takes absolute priority, and interventions for intracranial pressure can only follow once cervical injury is ruled out. Let us begin this question with a critical trauma scenario. A client has been admitted to the neurology unit following a traumatic head injury confirmed by imaging of the head, neck, and spine. The nurse prepares to conduct the first neurological assessment, and the key question is, which assessment finding requires the highest priority attention to detect potentially life-threatening complications? Here are the options to consider. The first option is lung sounds. The second option is clarity of speech. The third option is mobility of fingers. And the fourth option is pupillary responses. The correct answer is option 4, pupillary responses. Changes in the size, shape, and reactivity of pupils are among the earliest and most reliable indicators of rising intracranial pressure or evolving brain herniation. Because the oculomotor nerve is quickly affected by cerebral edema or hemorrhage, even subtle pupillary changes demand immediate attention. A dilated and fixed pupil can signal transtentorial herniation, while bilateral dilated and non-reactive pupils reflect brainstem damage. Recognizing these early is critical, as uncontrolled intracranial pressure quickly reduces cerebral perfusion, causes hypoxia and ischemia, and may lead to irreversible brain damage. Looking at the incorrect options, we can start with lung sounds. While assessing breath sounds is essential in trauma patients to detect aspiration, infection, or atelectasis, it does not provide urgent neurological data. Once airway and breathing are stabilized, the neurological system must be prioritized. Next, consider clarity of speech. Assessing speech helps evaluate cranial nerve and cortical function, but slurred or incoherent speech usually occurs later and is not as life-threatening as rapid pupillary changes. Speech alterations are important, but not as immediate as the warning signs revealed through pupil assessment. Finally, examine mobility of fingers. Testing motor function helps assess spinal cord involvement or focal cerebral injury. However, motor weakness or hemiparesis often appears after pupillary changes, making it a less sensitive early indicator of rising intracranial pressure. From a clinical reasoning standpoint, after ensuring airway, breathing, and circulation, the nurse must prioritize neurological signs that reveal the most imminent danger. Pupillary checks provide direct, objective evidence of brainstem integrity and are essential in guiding urgent interventions like elevating the head of bed, giving osmotic diuretics such as Mannitol, or preparing for surgical decompression. Here is an NCLEX strategy tip. When answering prioritization questions, always choose the assessment that detects the earliest and most life-threatening changes. Pupils reveal the silent story before motor and speech changes do. A fixed or unequal pupil is an emergency red flag. Stan Coast Pearl. In clients with head injury, pupillary changes act as the earliest red flag warning of rising intracranial pressure. A single unequal or fixed pupil can precede catastrophic herniation, respiratory failure, and even cardiac arrest. Always prioritize pupil assessment to preserve both life and brain function. Let us move into this critical neuroassessment scenario to sharpen your NCLEX reasoning. A nurse is caring for a client who sustained a closed head injury following a motor vehicle accident. During the shift assessment, the nurse gathers multiple findings, but the key question is, which one must be reported to the healthcare provider immediately, as it signals a potentially life-threatening complication? Here are the possible options to weigh carefully. The first option is that the client rates a headache as 5 on a scale of 0 to 10. The second option is that the client leaves most of the food untouched on the dietary tray. The third option is that the client is difficult to arouse, even with vigorous stimulation. The fourth option is that the client complains of feeling unusually cold. The correct answer is option 3. The client is difficult to arouse, even with vigorous stimulation. A decreasing level of consciousness is the earliest and most sensitive clinical indicator of increased intracranial pressure. When brain tissue swells or bleeds, it compresses the reticular activating system in the brainstem, which directly controls arousal and wakefulness. A client who shifts from alert to lethargic or becomes unresponsive is flashing a red alert for worsening cerebral edema, herniation, or even impending respiratory failure. This is an emergency, and immediate action includes notifying the provider, elevating the head of the bed, preparing for osmotic therapy like Mannitol or hypertonic saline, and ensuring airway protection. Now, let us look at why the other options are less urgent. Headaches, such as in option 1, where the client rates pain as 5 out of 10, are common after head trauma. They may result from concussion, cerebral edema, or meningeal irritation. While documentation and management with analgesics are appropriate, a moderate headache alone does not indicate an imminent herniation risk. Moving to option 2, leaving food untouched suggests poor appetite, nausea, or emotional distress. While nutrition is important for healing, decreased intake is not a neurological emergency and can be addressed through routine care strategies. Turning to option 4, the complaint of feeling cold may reflect environmental factors, altered circulation, or metabolic responses to trauma. Although persistent hypothermia can affect recovery, an isolated sensation of cold is not a hallmark of dangerous intracranial pressure elevation. To integrate this clinically, always remember that changes in level of consciousness precede changes in vital signs such as Cushing's triad, as well as pupillary alterations or motor deficits. In practice, this means that neurological red flags such as decreasing arousability, unequal pupils, seizures, or abnormal breathing patterns always take priority over nonspecific complaints like headache, appetite loss, or temperature sensations. Evidence-based neurotrauma guidelines consistently emphasize that LOC is the earliest and most reliable marker of worsening intracranial pressure. Here is the Stan Coast Pearl. In any client with head injury, the very first red siren is when they become harder to wake. Pupils, motor deficits, and vital sign changes usually follow later. Recognizing this early and acting decisively can prevent catastrophic brain herniation and save a life. Let us shift into another essential neuroassessment question that is highly testable on the NCLEX. A nurse is monitoring a client who sustained a closed head injury after a fall. During reassessment, the nurse notices a sudden change in the client's neurological status. The question to consider is this: which factor is most likely contributing to this deterioration? The available options are as follows. The first option is that the client has been disturbed every hour. The second option is that the client has had very little fluid intake. The third option is that the client's neck is flexed toward the chest. And the fourth option is that the client's bladder is becoming quite full. Now, the correct answer is option 3. The client's neck is flexed toward the chest. Flexion of the neck compresses the jugular veins and obstructs venous outflow from the brain. This results in venous congestion, which increases intracranial pressure. Even small elevations in intracranial pressure can dramatically reduce cerebral perfusion, leading to ischemia, swelling, and worsening neurological function. That is why proper positioning after a head injury is a priority intervention. The head should be maintained in a neutral midline position, elevated about 30 degrees, and never flexed or rotated. These adjustments are simple but life-saving because they optimize venous drainage and oxygen delivery to brain tissue, ultimately preventing complications such as cerebral herniation. Turning to the incorrect answers, the first option, that the client has been disturbed every hour, does not directly raise intracranial pressure. In fact, frequent neurological checks are a required part of head injury monitoring. While they may interrupt rest and cause irritability, they are not the root cause of acute neurological decline. Moving to the second option, very little fluid intake is actually a protective measure in head-injured clients. Fluid restriction is often ordered to prevent cerebral edema. Low intake of fluids alone does not cause immediate neurological deterioration, though prolonged restriction may risk dehydration. Finally, the fourth option, that the client's bladder is becoming full, is a valid concern, but not in this scenario. A distended bladder may trigger autonomic dysreflexia, but that occurs in spinal cord injuries above the level of T6, not in clients with head trauma. Although urinary retention can cause discomfort and agitation, it is not responsible for an acute rise in intracranial pressure. Here is your Stancoast Pearl. In traumatic brain injury management, positioning is everything. Always keep the head midline, avoid neck flexion or tight ties that restrict venous return, elevate the head of the bed to 30 degrees, and minimize hip flexion. These non-invasive interventions are first-line strategies for controlling intracranial pressure and protecting fragile brain tissue from further damage. Let us move into the next critical question to sharpen your NCLEX preparation. A client with increased intracranial pressure following a traumatic brain injury is prescribed Mannitol, also known as osmotrol. This osmotic diuretic works by creating an osmotic gradient that pulls fluid from cerebral tissue into the vascular space. The question to ask is, which nursing assessment is the most critical to determine the client's response and detect potential complications of this therapy? Here are the options. The first option is urine output. The second option is respiratory rate. The third option is level of pain. And the fourth option is blood pressure. The correct answer is option 1, urine output. Monitoring urine output is the priority because both the therapeutic effect and the adverse consequences of mannitol are reflected in renal excretion. Mannitol increases plasma osmolality, which draws water out of edematous brain tissue into circulation, and the kidneys excrete the excess water. Adequate urine output confirms that the drug is effective and that renal perfusion remains intact. However, excessive diuresis may lead to hypovolemia, dehydration, and dangerous electrolyte imbalances such as hyponatremia and hypokalemia. If urine output decreases significantly, showing oliguria or anuria, it may signal renal impairment or mannitol crystallization within the renal tubules, both of which can be life-threatening. For this reason, strict intake and output measurement, daily weight monitoring, and frequent laboratory tests such as blood urea nitrogen, creatinine, and electrolytes are essential in guiding safe therapy. Now, looking at option 2, respiratory rate. While monitoring breathing is always important, mannitol does not directly depress or stimulate respiratory drive. Any breathing complications in this client would be more related to neurological injury rather than the drug itself, making this option incorrect. Shifting to option 3, level of pain. Pain assessment is indeed important in all clients, especially in those with head trauma. However, pain levels do not provide information about the effectiveness or risks of mannitol therapy. Overfocusing on pain could delay recognition of renal compromise or fluid and electrolyte imbalance, making this choice less critical. Finally, option 4, blood pressure, deserves attention because mannitol can cause hypotension through intravascular fluid shifts. Yet, hypotension is a later secondary effect. Urine output is a more immediate and reliable marker of both the therapeutic response and the risks associated with mannitol therapy, making it the most critical assessment. Here are some high-yield clinical integrations. Mannitol works by being freely filtered at the glomeruli without being reabsorbed, thereby creating an osmotic pull that drags water into the renal tubules. Its key indications include elevated intracranial pressure, cerebral edema, acute glaucoma, and the prevention of renal failure in hypovolemic shock. Nurses must closely monitor intake and output, serum osmolality, electrolytes, daily weight, and neurological status. Complications include pulmonary edema due to fluid shifts, dehydration, hypotension, rebound intracranial pressure, and even acute kidney injury. One vital nursing priority is to always use a filtered intravenous set when administering mannitol, because it has a tendency to crystallize at room temperature. The solution should be warmed if crystals appear before administration. And here comes your Stancoast Pearl. Think of U for urine in mannitol use. The very first and most critical clue to both effectiveness and safety with mannitol therapy is urine output. If the kidneys do not respond appropriately, mannitol shifts from being a therapeutic ally to a dangerous threat. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000. Nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner. Nigerian Naira questions broken down in detail during comprehensive lectures. This isn't just another review. It's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources. 2. Keep you ahead. Let us move into this important spinal cord injury question to strengthen your NCLEX preparation. After a diving accident, a 22-year-old client is diagnosed with a complete transection of the spinal cord at the 5th thoracic vertebral level. During discharge teaching, the nurse asks, which client statement demonstrates an accurate understanding of the prognosis and functional expectations? The possible answers are as follows. The first option is, after surgery, I can expect to regain full function. The second option is, I will always depend on others to feed and bathe me. The third option is, I will retain functions above my chest, including movement of my arms and hands. And the fourth option is, it is impossible to predict what my long-term abilities will be. Now, let us reveal the correct answer. The right choice is option 3. I will retain functions above my chest, including movement of my arms and hands. This is correct because with a complete spinal cord transection at the T5 level, the individual permanently loses motor and sensory function below the chest, resulting in paraplegia. However, the cervical nerves and upper thoracic nerves remain intact, so arm, hand, and diaphragm function are preserved. This means the client will be able to breathe independently, perform self-feeding and grooming, and engage in upper body activities of daily living. Rehabilitation focuses on independence and mobility through wheelchair use, as well as prevention of complications such as autonomic dysreflexia, spasticity, and pressure injuries. Shifting attention to option 1, after surgery, I can expect to regain full function. This is incorrect. Unlike peripheral nerves, the central nervous system has minimal regenerative ability. Once a complete transection occurs, there is no recovery of function below the level of injury. Surgical procedures are aimed at stabilization and prevention of further damage, not restoration of lost function. Looking at option 2, I will always depend on others to feed and bathe me. This is also incorrect. Even though lower limb paralysis is permanent, the client still has full use of their arms and hands. With proper rehabilitation and adaptive devices, most individuals with T5 paraplegia remain independent in feeding, grooming, transfers, and many other daily tasks. They do not require complete dependency for care. Finally, option 4, it is impossible to predict what my long-term abilities will be, is not accurate in this situation. While incomplete spinal cord injuries carry uncertain prognoses due to variable recovery, a complete transection at T5 has a predictable outcome, permanent paraplegia below the level of injury. The client will not regain lower body function, though independence in upper body activities remains possible. Stan Coast, Pearl. Cervical equals arms, thoracic equals chest, lumbar equals legs. At the T5 level, the arms and hands are preserved, chest muscles above the lesion are intact, but the legs remain permanently paralyzed. This simple memory aid helps you quickly connect spinal cord levels to functional outcomes on the NCLEX. Let us now move into another important NCLEX-style scenario that focuses on spinal cord injury rehabilitation. After medical stabilization, a client with a complete spinal cord injury at the thoracic level is transferred to a rehabilitation unit. During the initial interdisciplinary team conference, the nurse must decide which intervention should take the highest priority in the client's rehabilitation plan. The possible options are as follows. The first option is teaching the client about prevention of skin breakdown. The second option is strengthening the client's upper body muscles. The third option is confronting the client's denial of the prognosis. And the fourth option is letting the client verbalize about the accident. The correct answer here is option 2, strengthening the client's upper body muscles. This is the top priority because in clients with paraplegia, lower limb paralysis is permanent, But functional independence can still be achieved through preserved upper extremity strength. By focusing on muscle conditioning in the arms, shoulders, and chest, the client gains the ability to transfer from bed to wheelchair, propel the wheelchair, perform self-care, such as feeding, grooming, and dressing, and most importantly, maintain dignity and independence. From an NCLEX prioritization standpoint, interventions that directly promote physiologic stability, safety, and long-term functional outcomes outweigh psychosocial needs at this stage. Furthermore, strong upper body function helps reduce the risk of contractures, respiratory complications, and caregiver dependence. Looking at the other options first, teaching the client about prevention of skin breakdown is certainly important, since immobility and reduced sensation increase the risk of pressure injuries. However, education alone is not sufficient if the client lacks the physical strength to reposition independently. Strengthening the upper body lays the foundation for pressure injury prevention by allowing the client to shift weight and move safely. Next, confronting the client's denial of the prognosis may seem useful from a psychosocial standpoint, but it is not an immediate priority. In fact, doing this too early can create resistance and hinder emotional adjustment. According to Maslow's hierarchy and NCLEX frameworks, physical adaptation and safety must be addressed first, with psychosocial interventions introduced gradually once independence and stability are established. Finally, letting the client verbalize about the accident is therapeutic and helpful for emotional healing, but it does not directly affect physical recovery or functional independence. If physical capacity is not strengthened, the client is at higher risk for long-term depression, dependency, and secondary complications, making this option less urgent compared to upper body conditioning. To summarize, Maslow's hierarchy places physiologic function above psychosocial needs, and NCLEX safety and physiologic adaptation categories emphasize physical rehabilitation before emotional processing. In spinal cord rehabilitation, the first priority is empowering the client to regain maximal independence and prevent complications, which begins with strengthening available muscle groups. Here is your Stan Coast Pearl. Stronger arms, stronger independence. For clients with thoracic spinal cord injuries, upper body strength is the cornerstone of mobility, self-care, and dignity. Moving on to another critical situation you may see on the NCLEX. Imagine a nurse working in a rehabilitation unit who is assessing a client with a T6 spinal cord injury. Suddenly, the client develops flushing of the face, profuse sweating above the level of injury, and begins to complain of a pounding headache. Immediately, the nurse suspects autonomic dysreflexia, a life-threatening emergency that often develops after spinal shock has resolved. The question asks, which clinical manifestations should the nurse expect to observe in this client? Here are the possible options: severe hypertension, rapid heart rate, pounding headache, pale skin below the level of injury, blurred vision, and nasal stuffiness. The correct answers are severe hypertension, pounding headache, blurred vision, and nasal stuffiness. Now, let us break down the reasoning step by step. Severe hypertension is a hallmark and dangerous feature of autonomic dysreflexia. It happens when noxious stimuli such as bladder distension, bowel impaction, or even tight clothing trigger an exaggerated sympathetic discharge below the level of the injury. Because inhibitory signals from the brain cannot travel past the damaged cord, blood vessels constrict powerfully, and the blood pressure can skyrocket 20 to 40 millimeters of mercury above baseline. If not controlled, this extreme hypertension can cause seizures, stroke, or even death. Rapid heart rate, on the other hand, is not expected. Instead, the opposite occurs. Reflex bradycardia develops. This happens because the vagus nerve remains intact, and baroreceptors in the carotid sinus attempt to slow the heart in response to the severe hypertension. So, tachycardia is actually incorrect. Pounding headache is a very typical finding, often described by clients as sudden and severe, usually in the occipital area. It directly results from the massive rise in blood pressure, increased intracranial pressure, and vascular engorgement, and it serves as one of the earliest red flag symptoms. Pale skin may sound reasonable, but in reality, the clinical picture is different depending on the body region. Above the lesion, clients are flushed, warm, and sweaty, while below the lesion, the skin is cool and pale due to vasoconstriction. Since the question did not specify below the lesion, simply stating pale skin is not considered a primary expected finding. Blurred vision is another correct manifestation. The hypertensive crisis can impair cerebral circulation and cause vascular congestion, leading to visual disturbances, flashes, or even transient blindness if left untreated. Finally, nasal stuffiness is a surprisingly classic feature of autonomic dysreflexia. It results from vasodilation of the nasal mucosa above the level of injury, and although it might appear minor, it is actually a textbook sign that goes along with flushing, sweating, and headache. In clinical practice, autonomic dysreflexia most often occurs in clients with spinal cord injuries at T6 or above. Common triggers include bladder obstruction, fecal impaction, skin breakdown, or restrictive clothing. If not recognized quickly, the condition can progress to seizures, retinal hemorrhage, or death. Immediate nursing priorities are to first place the client in an upright position to decrease cerebral perfusion pressure, loosen any restrictive clothing or devices, and check for bladder or bowel causes, because a blocked catheter or distended bladder is the most common trigger. If symptoms persist, antihypertensive medications such as nifedipine may be needed. Here is your Stancoast Pearl to seal this into memory. Think HBAN in autonomic dysreflexia, hypertension, blurred vision, autonomic headache, and nasal stuffiness. And remember, always check the bladder and bowel first, because a full bladder is the #1 culprit. Now, let us turn our attention to another crucial NCLEX-style scenario that emphasizes both safety and long-term client management. A nurse is developing a bowel retraining program for a client with a T8 spinal cord injury. This client has a history of experiencing episodes of autonomic dysreflexia triggered by fecal impaction, making bowel management not just about comfort but about preventing life-threatening emergencies. The question asks, which nursing intervention is the most appropriate to promote regular bowel elimination and prevent complications? Here are the options to consider. Option 1 suggests administering a stool softener twice per week. Option 2 recommends encouraging the client to consume a high-fiber diet. Option 3 proposes having the client drink 2 glasses of water every morning. Option 4 advises teaching the client to self-administer daily enemas. The correct answer is Option 2, encouraging the client to consume a high-fiber diet. This is correct because a high-fiber diet plays a foundational role in establishing a predictable bowel routine. Fiber works by increasing stool bulk, attracting water, and softening stool consistency, which together stimulate peristalsis and support easier evacuation. For clients with spinal cord injuries, maintaining regular bowel movements is absolutely essential, not only for comfort, but also for preventing autonomic dysreflexia, a potentially life-threatening condition characterized by severe hypertension, pounding headache, blurred vision, and bradycardia. By ensuring adequate fiber intake, the nurse helps reduce the likelihood of constipation and fecal impaction, which are major triggers of this complication. Best practice also combines high fiber intake with sufficient hydration, ideally 8 or more glasses of water per day, and scheduled bowel routines timed with the gastrocolic reflex, such as after meals. On the other hand, option 1, administering a stool softener twice per week, is incorrect. While stool softeners like docusate sodium can help by moistening stool, giving them only twice weekly is not sufficient for consistent bowel retraining. The purpose of bowel programs in spinal cord injury clients is to establish predictability, and irregular dosing fails to prevent constipation and impaction, thus increasing the risk of autonomic dysreflexia. Next, option 3, having the client drink 2 glasses of water every morning may sound helpful, but is also incorrect. Hydration is indeed critical for stool consistency and urinary tract health, but limiting fluid intake to only 2 glasses in the morning is inadequate. Clients with spinal cord injuries generally require 2 to 3 liters of fluid throughout the day. Starting the morning with water is a good step, but it cannot serve as a standalone intervention for bowel retraining. Finally, option 4, teaching the client to self-administer daily enemas, is also inappropriate. Daily enemas are excessive, may cause bowel dependence, and can irritate the mucosa. Enemas are typically reserved for refractory constipation or fecal impaction, and are best timed after meals to enhance the gastrocolic reflex. Relying on them daily disregards the natural process of bowel regulation and exposes the client to unnecessary risks, including electrolyte imbalances. And here is the clinical pearl to lock this concept into your memory. In clients with spinal cord injuries, bowel retraining is not just a comfort measure. It is a critical strategy for preventing autonomic dysreflexia. The gold standard approach includes a high-fiber diet, adequate hydration, and routine scheduling with the gastrocolic reflex. Remember this, fiber without fluids is ineffective, and enemas used too frequently can do more harm than good. Let us now move into the next high-yield scenario that highlights the critical role of environmental adaptations in spinal cord injury rehabilitation. A nurse is preparing for the discharge of a client who sustained a thoracic-level spinal cord injury 6 months ago. The client is anxious about maintaining independence in activities of daily living and mobility both inside the home and in the community. The question is, which home modification is the most essential for promoting long-term mobility and functional independence? Here are the options to carefully consider. Option 1 suggests renting or buying a conventional hospital bed. Option 2 proposes building a wheelchair ramp to the door. Option 3 recommends applying for a handicapped parking sticker. Option 4 advises providing a raised toilet seat with grab bars. The correct answer is Option 2, building a wheelchair ramp to the door. This intervention directly removes one of the biggest barriers faced by individuals in wheelchairs, the inability to independently exit and enter their own homes. Without this adaptation, even the best mobility training or equipment cannot guarantee functional independence. Installing a ramp aligns with universal design principles and is supported by the Americans with Disabilities Act, which emphasizes accessibility as the foundation of community participation. It empowers the client to attend appointments, socialize, return to work or education, and reduce dependence on caregivers, thereby promoting psychological well-being and long-term adjustment. Looking at Option 1, renting or buying a hospital bed may assist with comfort, positioning, and skincare, but it does not enhance the client's mobility. It is a supportive tool for in-home care, but does not extend independence beyond the bedroom. Turning to Option 3, applying for a handicapped parking sticker certainly improves accessibility in public spaces by reducing walking distances and conserving energy, but this benefit is secondary. If the client cannot even leave the home without assistance, the sticker loses its relevance. Considering Option 4, providing a raised toilet seat with grab bars enhances bathroom safety and independence for transfers. Yet it is a task-specific modification rather than a global solution. Moreover, if the seat height is not aligned properly with the wheelchair, it may create additional risks during transfers. Here is the clinical pearl to remember. Mobility starts at the door. For spinal cord injury clients, the very first step toward independence is ensuring they can get in and out of their homes without barriers. Nurses must collaborate with occupational and physical therapists as well as social workers to ensure such modifications are prioritized in discharge planning. This way, the client's journey toward independence is not only preserved, but truly empowered. Thank you for joining. Stay focused, stay confident, and remember, your knowledge can save lives.